The following content is for informational purposes only and should not be considered medical advice.
Welcome to KC Wellness Talks. I'm Dr. Dawn Ipsen, pharmacist and your host. Join us as we delve into the world of healthcare with local providers discussing common health concerns many face and explore ways to overcome them. Whether it's simple tips for home remedies or the latest in treatment technologies, we've got you covered. Today, I am so excited. I'm on location at Alpine Integrative Medicine in Redmond, Washington. I'm getting an opportunity to interview a longtime friend, colleague, provider, doctor, amazing provider in our area. So thank you for being here today.
Thank you so much for having me. We won't talk about how long we've known each other, though.
No, because that starts to put dates and ages together. And we don't need that because, you know how old my kids are and I know how old yours are now, too. So
Yeah.
want to do a little introduction so our audience knows who we're meeting with today. This is Dr. Brooke Azie-Rentz, and she is a naturopathic physician, founder and medical director of Alpine Integrated Medicine here in Redmond, Washington. Beautiful location in a fun neighborhood here. She runs a concierge naturopathic primary care clinic and specializes in lots of things, but primarily women's health, primary care, bioidentical hormone replacement, and also integrating evidence-based naturopathic approaches to all types of preventive and lifestyle medicine. We're going to talk about lots of little bits of that and how they all interplay, which is why you're an expert in so many things. She is a 2005 graduate of Bastyr University. Dr. Brooke is committed to advancing her profession through mentorship of students and residents. How long have you had your residency program?
Going on, this is our eighth resident, so.
And I think you were one of the first naturopathic physician clinics in the area to even start having residency programs and continued it for this longevity.
Well, our clinic was one of the founding members of the INM residency program. Okay. So we really started to do that probably about 10 years ago, and we had a beta test through here, and there was other residencies around before that, but yeah.
Yeah, I knew that you were a mover and shaker.
Yep.
And super dedicated in that, which we really appreciate too. Also, your leadership is profound. You've been on the board of directors for the Washington Association of Naturopathic Physicians. You're a current board member of the Institute for Natural Medicine, which that's an amazing group too. And I love your philosophy. Do you want to just tell us a little bit about your overall philosophy?
It's really about meeting people where they're at, whole person health, and doing what is right for the person without me letting my ego get in the way. I want to let you decide how your medicine is going to be, and I'm just there to make sure that you do it safely and effectively.
I love that. You're a super tremendous guide and mentor for patients in that, and I know that they connect really, really well with you. I get to talk with some of your patients at different times.
Yeah.
So what inspired you to be a naturopathic physician and lead into opening your concierge care clinic?
Well, I mean, that goes back just about 2 or 3 years ago. Just kidding.
Otherwise, you would have been 10 at the time.
So my undergrad was physical therapy. So I actually wanted to, I was a big athlete as a kid, and I always wanted to be the person that ran out in the field and, with the Seahawks and fixed that athlete. But back in those days, women weren't allowed in the locker rooms of professional athletes. And I didn't find that out until I was already partway through my schooling. So I decided basically that I wanted to do something else. And so I kind of looked around, and I'm from New England area. I was in my undergrad in Maine. And I started looking for, where I would want to go to medical school. And I happened to stumble across a website for Bastyr. Having never heard about naturopathic medicine, it really, that time hadn't really hit the East Coast yet.
Yeah.
And so I found it. I read their mission statement. I was like, wow, that is everything I believe about medicine. And I had to overnight my application here, and here I am.
Oh my gosh, that had to have been the hugest move ever from New England to Seattle. Had you ever even visited before?
I had never been west of the Appalachian Mountains.
Oh my God.
So for my interview, I actually flew to California and flew up here and stayed at the campus, got here at midnight.
Oh gosh.
And if you have never been to Bastyr, it's up at St. Edward's Park, and it's a beautiful campus. Mm-hmm. But arriving at midnight, I didn't see it, and I woke up, it was April, to this springtime in Seattle, beautiful fairy tale world, and was like, I'm coming here and I'm never leaving.
Oh my gosh.
And here I am, still.
That's amazing.
Yeah.
And then how did your journey go through? You got your degree, you went out in practice, and you said, wait, concierge model is what we need to do.
Yeah, as naturopaths, we spend a lot more time with our patients,
Yes.
And it's really delving in. And there's something called a pathobiography, and I really like that word. And it's the idea of, I want to know your whole life story and what brought you to this point. Because, the way you were raised and the food you ate and where you breastfed and all those things will tie into who you are as a person today. So doing that and coming out of practice, I realized that the medical model of 10 or 15-minute visits really only allowed you to see one thing at a time. And most of the time, people come in and they have 5 complaints, and they are all linked together somehow. And so I find that I personally, and I think naturopaths are really good at, again, looking at that whole person and seeing how does your stomach relate to your skin, relate to your mood. And in the conventional world, it's really about, you should see a psychologist, you should see an endocrinologist. And though there's a time and a place for people to be sent to those, can we look at the whole model? And so concierge was something that really allowed me to spend more time with patients and really delve into that a little bit more. In a world of our clinic, we do take insurance as well as the concierge. Okay. So we wanted to find a way that we could bill insurance and also get paid for the things that we did that were above and beyond what insurance was going to pay for.
Oh, that's super awesome. I didn't realize that you took insurance for some aspects of what could be covered. That's great.
Yeah, so people come in and their office visits are paid for, their gyne visits are paid for, but it's the extra things that we do, the hour-long visit, the talking about supplements or nutrition or diet that insurance doesn't always pay for, that's what our concierge is for. So it's a little bit different than the direct pay model that doesn't take insurance. Right? That's you pay an amount and you get a certain amount of services per month. Ours is, it's kind of more like a retainer with a lawyer. You're paying to keep me so that anytime you need me, you can call and I'm there on the phone for you. Or I answer emails all the time and I don't charge you every time you email me, which is what some clinics do, right? So it's just a way to not nickel and dime the patient and get you the best care possible.
What type of patient would be a good fit for that type of model, or who tends to really fit in well in this?
Honestly, anyone. I mean, I think that people think about kind of the corporate wellness model. So the people are CEOs that want their, doctor to do everything for them and be there for them. And there are models like that out there. But ours is really for people that just want that person that's thinking of them a little bit more, that they can email and contact and say, hey, I'm, whether it's I have this rash, what should I do? Or, I have a stomach ache, should I go to the hospital? Like it's just having that more direct contact. And then for me, I limit my patients. So I'm limited to 250 active patients at any time. So what that means is you can call and you can get in with me right away. Like I have spots to get you in that day or the next day if it's an emergency, getting you in, not waiting 3 months to see your doctor for something, right? So
totally incredible.
Yeah.
I really support this model, and I'm hopeful that this is the way that healthcare is going to go, because I do think, like you said, patients deserve to have longer time spent with them and looking at connections between you're in for a rash, but what's your stomach doing at the same time, and how does that interplay? And
I think that it is actually, we've been doing it for 10 years now. We were kind of innovators in it in this area. But I think more and more people are going to it because doctors in general, no matter if they're conventional or naturopathic, I think people realize that a 10-minute visit isn't enough to treat people. And I think patients want more than that. They demand more than that.
Absolutely. So, I think that's very true too. Now, I know from when we worked together that one of the things that you are very proficient and adept and successful with is helping women, and helping women with hormone balance in all stages of their life. How do you decide with that who's a good candidate for hormones, and how do you look at that picture and that type of patient? Yeah,
hormones are very controversial, as you know, and I think that, unfortunately, there have been studies that have been done that have done women a disservice, and they have made it so that there won't be any legitimate double-blind placebo studies done going forward in any of our lifetimes or our granddaughters' lifetimes. And so everything that has to be done is kind of retroactive. So, I really think that women specifically should, but all patients should have a choice in their healthcare of how things are done. And when it comes to hormones, these studies have said, estrogen is bad. It causes cancer. And I don't agree with that. I think there's lots of studies that show that there's lots of things that can lead to cancer.
For sure.
And you can never have touched hormones in your life, not birth control pills, not estradiol at menopause, and still end up with cancer.
Right.
So, I think that to me, it's about quality of life and education. So I educate my patients a lot. I give them reading assignments to do.
Homework.
Yeah. And,
wow.
and I want people to have questions because I believe that, like I said in the beginning, I'm here to facilitate people's health in a way that they want to do it that's safe and effective.
Right.
And so I have lots of different ways that I do hormones here. And there are some people that have had cancer that we do smaller amounts of hormones, or we do certain delivery methods of hormones, like vaginal delivery, or we use more of a food-based, maca or something like that, that is definitely not going to raise their levels as high and work differently. And then there are people that need really, really high dose hormone because you check their blood or their symptoms and they don't get better on some of those low dose things. And this is where a new study came out in February from Menopause, and it was done in Europe. It was Menopause Journal, and they followed women, lots of women, all different ages, on all different kinds of hormones, patches, creams, pellets, and they measured their levels and they asked for their symptoms. And they found that if we kept an estradiol at 100 on your peak day of your estrogen, that there was, it was 100% resolution of hot flashes in the study. And then it showed very much decreased dementia and Alzheimer's, breast cancer, quality of life was improved. And what they said is that it differed, that number differed depending on how old you were. Were you 25, 45, 65? Were you on a patch, a cream, a pellet? And that we needed different doses for people wherever they were in their phase of life, depending on, what their body habitus was, because fat and estrone go together. And so it was really interesting to just see that one size does not fit all for hormones. And just because your girlfriend is on this patch doesn't mean it's going to work for you, and maybe you need a cream instead.
That's very true.
So here at AIM, with hormones, we really try and make sure that it's not one size fits all. That it's what's gonna, if you have young children, if you work in the water all day long, if you have a small animal that you tuck under your arm, a cream is not going to be the right choice for you. Right. If
transferring it all day long to everybody they're touching.
Exactly. So that's part of the pathobiography. What do you do for a living? How do you sleep? Do you sleep naked and you don't want to pass that to the person in your bed? Do you have 4 dogs in your bed at night?
Licking you because your cream smells so nice.
Exactly. Right. So I think that those are all the things that we have to look at when we make choices for women specifically around hormones. Is what's the right choice? And then if you have a family history of breast cancer or a personal history, having conversations about what options are there for you, right?
And thank goodness we have so many options.
Absolutely.
That, and part of that is obviously through the compounding pharmacy, where I work and have, and, but there's other things as well. And you're right, it's really figuring out what's the best for them at that time in their life and for how long do they need it and what can they be compliant with.
Well, you even help me. I have patients that I put them on a cream and they don't feel anything. Their numbers don't move. And I'm like, why? Do they need more? And you give them more. And it still doesn't work. And what do? We change the base cream. And you're always so great about sending people, like someone's got a rash where they applied it. And you'll send them blank creams. And we'll figure out which one doesn't give you a rash. Then we'll put the hormone in it.
Let's figure out the easy part first with base. And then we'll go from there.
But that's what it is that we are all individuals. Our chemistry is individual. What we put on our skin for creams, how we wash, and all that contributes to how things are absorbed and how we feel.
Yeah, I agree with that so much. And I love that it's just an individual patient scenario and meeting where they're at. And, there are so many misconceptions in there. And I do love and appreciate that in the last 2 or 3 years, we've had a few, and one of the studies you mentioned is a really good one, but a few really good studies that are sort of debunking some of the beliefs we held before or thoughts that we were concerned about. So we're getting there. What's interesting, I was just talking with another provider about this, is that the original studies in the early 2000s did such a disservice where everybody was pulled off hormones. And also doctors were no longer being trained on how to do hormones because the answer was no, we don't do that. So now we're back to an area where the study has clearly said hormones are likely beneficial for most women for help of menopausal symptoms, But we have a whole generation of doctors who have never been trained on
That's
what
really
to
the
do.
thing. Yeah.
And so now we're playing catch up.
Yeah.
Luckily, though, we have you and other doctors similar to you who questioned these things the whole time and said, let's figure out how do we do this in a safe way. So.
I always tell patients, you treat medicine like you treat things going out to a restaurant. If you order the steak and they bring you salmon, are you going to eat it? Right? No, because that's not what you ordered. So when you're paying for insurance, you're paying for a visit with me. You're here because you want care. And with Dr. Google now, like everyone can look up their symptoms and you can figure things out and you can look things up and you have questions, why didn't you run this test or can I get this test? And so I'm here to help you navigate, Dr. Google, what is real, what is fake, what should be ordered, what shouldn't. And then again, those studies, the big thing about those studies have come back and said not everything is bad, and maybe even it's beneficial, and we have to look at why. When are you starting hormones, right? And I think having those conversations earlier, right? I think that's something we want to talk about is when do we have this conversation, right?
Yeah, right.
The average age of menopause is 51.
Right.
But many women have symptoms starting in their late 30s.
Absolutely.
Right? And I think that they go to their doctor, and because of these bad studies, their doctors, older doctors that have been trained a long time ago, are afraid of estrogens. They go, oh, this is menopause, this is midlife.
You're going to be okay.
You're going to be okay. Maybe you should see a counselor.
Yes.
Maybe there's some other, antidepressants we can talk about.
Here's your sleeping pill.
Yeah, but that's not getting to the root cause.
Absolutely.
And when you get to the root cause, and at that time, I've had people that are in their 20s that need estrogen.
Yeah.
I've started people in their, 60s, because that's getting into that range where you don't want to start it much later.
Too late, yeah.
But I've had people that we start it and it's life-changing, and they go off of antidepressants and they go off of blood pressure medications and cholesterol meds. And so I really think you have to look around the age of 50 and what starts to get diagnosed.
Yes.
Heart disease, high cholesterol, diabetes, arthritis.
Obesity really flares up.
Absolutely, right? Breast cancer, let's just the elephant in the room, right?
Yep.
But why weren't those things happening when you were 25?
Right, because you had hormones.
Because you had hormones.
I know. It's funny you say that. I literally we have a new student who's on a rotation with us. And hormones, of course, are new to her, too, because they're not taught like this, like what we do at pharmacy school either. And she's a great student. She actually did her homework and started reading a hormone book that we had given her.
Love it.
Yeah, I know. It's the Pam Smith Women's Hormone, What You Need to Know About Hormones. It's a great book for really getting some feet under you of understanding what these hormones do and why they're important and all the different systems that they affect. And we were talking about that it's normal for women as young as in their 30s to need some sort of hormone support, and I was mentioning that it's it's almost too bad that we don't know how to figure out what the optimal hormone level is for a particular individual woman.
I am so glad you just said that.
Okay, cool.
For all of you out there watching this,
Yes.
my life would be so much easier if women had their hormones checked when they were 25.
That's exactly what I said to her. I said, what we need to do is we need to start making it normal that women, when they're typically feeling their best, which is usually around mid-20s, we're just feeling awesome. We've got energy. We don't have any symptoms. We have a sex life. Everything is just...
You can eat a donut and not put on 5 pounds.
My God. Is that a thing? It's wouldn't that be amazing if those women at that point, at their optimum, went and got their hormone levels done at day 19 through 21 of their cycle.
Yep.
And we just knew. Because, I'm on hormones. I've been on hormones a long time. But I don't know what my best estradiol is or what my best testosterone level is.
Well, I'll tell you, for me, I tell people to get their numbers checked on day 19 through 21, but also day 12. So you're trying to capture...
Okay.
Day 12 is going to be your peak of your estrogen in that follicular phase.
Okay.
And then day 21, assuming you have a normal 28-day cycle, that's perfect follicular and luteal phase.
in the little dreamland that we like to live in.
Perfect world.
Yes.
But day 21 would be your peak of progesterone.
Right.
So looking at those two numbers at those times, for a 25-year-old female with perfect periods, we're looking for a number of usually 350 to 550 on that day 12 of estradiol.
Dang.
So so if you're at 450 at 25, cool.
Yeah.
You come to me at 45 and your number's at 200, that's still a very, very good number.
Absolutely.
So other doctors will go, wow, your number is great.
Yeah.
But it's half of what it was when you were at your best. And so you very well could be feeling half as good as you did 20 years ago,
Yep.
and someone else who doesn't know you, hasn't been living in your skin,
Yes.
says your numbers are fine. You should go and talk to someone.
Absolutely. But that's also where even if you have a doctor who's educated in this, let's say, and you get that lab and that lab looks great, what we're stuck with then is we go off of subjective information,
Yes.
right? Well, okay, well, your lab looks pretty good, but how are you feeling? And okay, well, maybe we can fine tune this a little bit more, but we're still a little nervous because we don't know what normal is, right?
Right.
Yeah, we get really conservative and
Yeah, and then the issue is once you hit menopause, so definition, it's been a year since your last period.
oh my gosh, which the definition alone, it makes me twitch.
Yeah, because how many of you out there have
Yes.
gone 11 months without a period
Yep.
and then it restarted?
Yep.
You're not in menopause by medical definition.
By
right?
definition. But if you grab an FSH, it probably still...
Yeah, so your FSH and LH have to be sky high, right? Or your estradiol less than 50.
Right.
So that person that feels bad, that has an estrogen of 75,
Yeah.
their doctor's like, oh, your numbers are still good. You're not menopausal yet.
Yes.
Right?
You don't need estrogen
Yeah.
yet. You still got it.
I would tell you that I say that perimenopause is the 10 years
Yes.
surrounding the date of menopause.
Oh, God.
And it could be 3 years before that date and 7 years after, right?
Yeah.
Everyone is different.
Yes.
And, menopause is really about the change or the fluctuation of hormones.
Yes.
No one goes through puberty overnight.
Right.
Right?
True.
Takes a couple of years, right? You
Yeah.
get a little
On and
wider,
off.
you grow up, right?
Yeah.
Yeah, on and off, right? Your period comes and it goes away for 3 months. Same thing happens at menopause.
Yes.
Right? But what happens is one day we wake up and look in the mirror and we go, where did this wrinkle
Oh,
come from?
for
And where
real.
did this 5 pounds come from? And oh my God, I was drenched last night, right?
Yes.
If you think about it, it's been slowly happening.
Creeping
It's
up.
the boiling a frog phenomenon, right? And so, but then when you come in and see me, we've had it up to here at that point, right?
Right. I'm done. I can't take another day of this. Dr. Brooke, please intervene.
Exactly. So I think that it's just about figuring out where people are and what is normal, right?
Yeah.
What's normal for you is not normal for your mom or your girlfriend or
Yep.
whoever it is. And that's what I think is a big problem when we talk about menopause is everyone wants to compare you to the rest of the world. I want to
Yes.
compare you to you. And if you don't feel good and you don't feel like yourself, well, that's enough for us to talk about it and start looking at those questions.
Right. That's awesome. And with that, you just kind of hit on it too. There's interplay, right? Menopause hits, we start putting on weight. So now we're overweight. We see the donut and the 5 pound sticks. And I know that's a big portion of how you interplay a whole body system. Do you want to talk a little bit about weight loss and how you're dealing with that? Because I know it's such a big news item for people right now too.
So, I mean, again, at this point in life, I start looking at let's assume it's people our age, right?
Yeah,
we're in that
okay.
perimenopausal 29-year-old age.
Yes.
No, we're
Yeah.
kidding. But, again, perimenopause in that time, it can be in your 30s. There's
Yes.
some people who get premature ovarian failure at 25, right?
Yeah.
So one of the things actually just real quick that you touched on was where people start to feel symptoms.
Yes.
I think after they have babies. I think mid-30s, right? And I think the hormones go up and they're really high when you're pregnant and then they go flooding out of
Crash.
you. And if you have another baby right afterwards,
Sure.
the body goes up again.
Right.
And then your body's like ready, like, oh, every year you're just gonna have another baby,
Yeah,
right?
let's do this.
But if you don't, the hormones go down and then it's like, okay, they're not coming back because they're waiting for you to be pregnant again.
Right.
And so
Oh,
things...
that's such a good way to describe it.
Yeah.
That's exactly what a lot of women go through.
Yeah, and that's why I find kind of like mid-30s, most women are done having babies.
Yeah.
So when I start looking, I'm thinking about how are your hormones?
Yeah.
How is your thyroid? How is your iron? How are your cortisol, right? If you have, young kids, you're up all the time with young kids, your cortisol shot. If you have middle schoolers and high schoolers,
Your cortisol's still shot.
cortisol's still shot. You're driving everywhere and driving them around.
and then worried about them all day long.
Yeah, and then they go off to college, and though they're not home with you, now it's empty nest syndrome, and now it's a different stress because now most people are getting into their 50s. They have elderly parents that we're starting to take care of. We have, how's my job? What does my retirement look like? So there's different stresses. So I think looking at cortisol, thyroid, estrogen, those are all the things that I look at kind of around middle age, weight, for specifically talking about weight, right?
Yeah.
Kind of looking at those things as part of it.
Right.
And then again, whole person. What is the thing that we're going to use? Are we going to, is thyroid off? Is estrogen off, right? Estrogen being low is going to make your body make fat.
Right. Fluffy up.
Yeah, right? I like to call it the menopooch.
Yes.
Right? So that, and the reason why, your ovaries are right here.
Yeah.
So your body's trying to put fat
Store.
around your ovaries because it's trying to make your ovaries, your fat makes estrogen.
Yes.
And it's tricking your body into thinking it's coming from your ovaries because it's coming from down there.
Right. Well, okay. And, you know, I love being in medical because every day there's something more to learn. So, I mean, I learn new things every single day. And one of the coolest reminders, maybe I knew this before, but a reminder that I had totally forgotten about and relearned was that when you have low thyroid, you can have high cholesterol.
Yes. And do you know what makes estrogen?
Cholesterol.
Yeah, so it kind of makes sense. Your body, being smart,
Yeah.
when your estrogen goes down, it's like, let's make cholesterol so we can try and make more estrogen.
Oh my gosh.
Right? I can't tell you how many patients have come to me
Yeah.
that their doctor's like, oh, I need to put you on a statin,
Yes.
your cholesterol is going up.
Yes.
I put them on estrogen and their cholesterol just goes pew,
Right on down.
Right? It's crazy.
It is so crazy. It's so interlinked.
There's
It's
a common
just so
denominator
interlinked.
here.
Yes.
Which is loss of hormones. We're talking about women today, but men too, right?
Absolutely, with the testosterone
Absolutely.
levels. And they make estrogen and progesterone too, whether they
Yep.
like to know about it or not. But
Yeah.
Yeah.
But all those things come into play. So we look at around all those things and I try and treat all those things. But, you know, everyone comes to my door asking about GLPs these days, right? That is.
How can you not be at least curious
Yeah.
with how it's being presented and talked about and TikToked and Instagrammed and media, you know, drug magazine ads and everything.
Yeah,
like,
and you
right?
can speak to it much more than me. They've been around for, what, 30 years or
Yeah.
something like that? So this
Yeah.
isn't new.
No.
It's just popularized on social media.
Right.
So we do offer GLPs. Not everyone has diabetes. Not everyone is morbidly obese. But
Yeah.
let's face it, at menopause, everyone wants to lose 3 to 5 pounds, right? Like,
Or 10 to 15.
yeah.
Yeah.
So we do
Yeah.
talk about it.
Yeah.
You know, again, I'm really, you know, evidence-based, research-based. I want to make sure it's not something what I call organic. Do you have a thyroid problem? Is
Yes.
this low estrogen? Is
Right.
this cortisol? And if
Right.
those things are off, then let's treat those and see how the needle moves.
Move the needle.
Right?
Right.
And then if not, or there is, you know, maybe some glucose control, or maybe we have a BMI that's over 30.
Sure.
Right?
Sure.
Then talking about GLPs and using them, there's so
Yeah.
much good evidence not only on weight loss, but you know, dementia protection, cardiovascular protection, anti-inflammatory.
Yep.
I've had so many patients come in and joint pain has gone away, and you can say, well, they've lost 20 pounds.
Right.
Sure, but how do you explain the fact that their brain fog is gone?
Right. For
Right?
sure.
And
Yep.
so I think that there's so many reasons to use it. And now with compounding pharmacies, there's
Yeah.
lots of ways to get it, and that you can do lots of doses. So we're not
Right.
tied to you have to do the whatever the commercially available one is. Doing
Right.
things at a
Full
lot of people
dose, so to
yeah,
speak.
don't do full dose. We
Yeah.
can do microdosing.
Right.
Right. And I think
Right.
that there are benefits to
Yeah.
doing that in smaller ways for
Right.
long-term health benefits.
Yeah, I think-
Especially after we've maybe met our weight loss goals.
True, because there has to be life after being on a full dose GLP-1 too.
Yeah.
I mean, it's not something that most people can maintain either from a cost or
Right.
you know, injections and refrigerated and shipping and travel
Yeah.
and all these things that
And you're going to lose the weight. I mean, if the goal of going on it is to lose the weight, once you hit that goal, what happens next?
Right.
Right. And I think there are negatives of GLPs, right? They're not, you know.
they're not for everybody.
Yeah, they're not the bee's knees.
Yep.
And you know, so when we do it, we do a lot of education around it, right? We don't let people take a bottle home and see you in 3 months, right?
Right.
Everyone has to stand on. We have an in-body scale, but there's
Oh,
lots
yeah.
of different body composition scales out there. You can do
Right.
home use. Ours is big and fancy, but they make some for at home.
Yeah.
And really tracking weekly what
Right.
is happening to your muscle mass, because we know
Right.
that those GLPs decrease that.
Right.
There was I was reading an article. People always think of muscle. We see the celebrities that either lose it in their face, the Ozempic
The
face,
Ozempic face.
right?
I was just talking with another doctor yesterday about that.
Yeah, and it's
like,
real.
What do we do about it? I'm like, they've got to quit losing weight so fast.
Correct.
They have to be working intentionally to maintain their muscle.
Yeah.
And getting protein to help feed and
Exactly.
maintain that muscle.
And because some people are on higher doses that kill their appetite, they just don't eat.
no, and protein for sure, because it
Right.
slows through the transit
Right.
time, doesn't make them feel as good.
Right. So
Yeah.
we recommend that people lose no more than 3 to 5 pounds a month. And,
Okay,
you
and
know,
I love that because that's always been my soapbox too. 1 to 2 pounds a week. That's all
Yeah.
you should be doing.
yeah. Because after that, there's a rebound, a bounce back, right?
Absolutely.
And I think it's frustrating. I think people want, you know, you hear the stories of someone that loses
Yeah.
30 pounds in a month on Ozempic.
Yeah.
And that's great for that person. Now,
Right.
if that person was 400 pounds, then that might be what they need to lose that fast.
Right.
But if someone is 185 and needs to
Yeah.
lose maybe 10 pounds to get into their goal weight,
Yes.
you know, losing 10 pounds that fast might not be healthy for them, and losing it over the course of 3 months might actually maintain when they go off the medication or go on a much decreased dose. And then going back to the Ozempic phase, the article that I was reading
Oh, yes.
was talking about people that are starting to see pelvic floor dysfunction. So they're starting having incontinence because
Really?
your pelvic floor
There's
is a
no
muscle. Right? So women out there,
Ladies.
do your Kegels.
Listen up.
Yeah, you have to do your bicep curls and you have to do your pelvic floor crunches, right?
And what's the reminder? Every stoplight you hit, do Kegels during the stoplight, right?
Yep. Or every time you go to the bathroom,
Yes.
right? So, I mean, granted, there are way better things out there than Kegels nowadays.
Thank goodness.
But it really is, if you're going to go on a GLP, it's really important that you eat good fat, you eat good protein, you move your body every day, and you have to lift weights. You know, especially women that are in menopause, you have to start lifting heavy. It can't be these light weights. It can't be doing yoga and cardio.
Right.
There's so much research coming out on lifting weights, and we're talking like serious weight for women as we get
lift
older.
heavy.
Yeah.
Lift heavy for as long as you can.
Yeah.
Because it's not only great for your bones, it's great for your muscles. It'll help you with your balance to make sure you're not at risk of falling. Because we all know the data. If you fall and break your hip, it's not good.
Nope.
The outcomes are typically very, very bad.
Yeah.
That's awesome. So, okay, so you're talking about, yes, it's a tool. I agree with that 100%. There's lots of tools out there too, it seems like. And then with that lifestyle pace, the diet, the exercise, the sleep, and all that.
There's actually one of the things that we have here. We have a device from BTL called Emsculpt. We have the Emsculpt Neo, and they actually did a study of GLPs and Emsculpt, and they actually showed that people didn't lose muscle mass, right? It's a device you put on your abdomen, and it basically is like crunches on your abdomen. But it was something that people that didn't work out, that just did this, maintained their muscle, versus people that just did a GLP and didn't work out, they lost that muscle, right? So for those of you, if you can't work out for physical reasons, or you're really busy and you can't get in the, you know, I'm recommending that you do your 10,000 steps and then you try and work out heavy, you know, 3 days a week.
Lift.
If you can't do those things, there are things that you can do to kind of help so you don't have the negative side effects of those GLPs.
And the Emsculpt, does that go on abdomen only, or can you place it on other areas?
There's so many areas we can put it.
Really?
Yeah, we can do your arms, we can do your butt, we can do your inner thigh, we can get rid of that touching thigh, right? So there's so much that we can do.
Okay.
Yeah.
Okay. Just triggering the muscle to make it work a little bit while it's being.
Yeah, muscle does a full-on, it's called a super physiological contraction. So it's going above what you can do on your own.
Really?
Holding it at tetany. So when you do it on your abs, it's a 30-minute treatment that it's like doing 30,000 crunches in that treatment.
Oh my gosh.
So that would take months to get in that many crunches.
Yeah, we would never be able to do that. Oh my gosh. What does it feel like? Is it painful, or is there any...
It's a contraction. So
Okay, so
when
you
you're
feel
on the
it.
table, you feel like you're doing crunches, and it kind of brings you up off the table.
Yeah.
Everyone can handle it. You know,
Yes.
it's not painful.
Okay.
I'd say it feels like since we're talking to a bunch of women,
Yes.
it feels like a very strong pregnancy contraction.
Okay.
Right?
Oh, wow.
And when it
Okay.
happens, you feel it, kind of like
Yeah.
pregnancy, and when
Yeah.
the contraction stops, it's done. You don't
Breathe
feel
through
it
it.
anymore.
Yeah.
And then you get a break for a couple seconds, then it comes on again. So
Oh my
it's
gosh.
30 minutes back and forth of doing it. Anyone can handle it.
That's incredible.
Yeah.
So that would be great for somebody who's got like a knee injury and they're just not able to get out there and do that, or they have big limitations.
Yeah, absolutely. So for people like, again, a knee injury, someone ends up, they are in a knee immobilizer,
Yeah.
we can actually put these things on their muscles and maintain their muscle while they're not able to work out. So,
Wow.
you know, athletes that have
Yeah.
a sprained ankle, they're like, oh, what am I going to do? How am I going to run that race in 3 months?
Yeah.
We can actually keep the muscle
Keep
up.
the muscle
Yeah.
from atrophying.
Yeah.
Oh my gosh. So, and with that, you know, we're talking about hormones. That kind of led into thyroid, making sure that's balanced in a good spot, which kind of led into, you know, GLP-1s and weight loss in general and lifestyle things. Another tool that I know that you use, I'd like to hear more about, like how you use it and what are you thinking about with it, is low-dose naltrexone.
Yeah. I mean, honestly, I think you taught me the most about this. So we should watch your podcast.
Passion project. But you've become very, very skilled at that. And I know that it's something that your patients, that, you know, we get the feedback because we see the refills, we talk to them at the counter, we talk to them on the phone, that they really notice great impact with it.
Yeah. So, I mean, I think that We use it mostly for our autoimmune patients, right? But we've really gotten it. Again, you've talked to me about it for weight loss patients, you know,
yeah,
and you know, I think there was a new medication combo that came out with it.
Yeah, there's a commercial product that pairs a little bit higher dose of Naltrexone. I'll still call it low dose, but a little bit different dose, and they actually pair a drug called Wellbutrin in it as well, bupropion. So it's designed to kind of help with that food noise, the food addiction, the food eating situation. But yeah, so it can be used as a tool for weight loss in some doses, but then also that inflammation aspect.
And we've used it for things like Hashimoto's patients. We've used it for various itises, like especially things around the stomach, right?
Oh, okay.
So, I mean, we've even talked about using it topically for some people that had some weird kind of topical lesions to see if those things worked. So I think, you know, I'm still learning about LDN. I think that it's something that is a great tool. And when I really haven't had anything negative with it, I think that the thing is finding the dose that works. And that's something you really helped me realize is when I was originally trained, not by you, everything was 4.5, and you know, and that was the top dose. And I think that what I've seen is that some people need a little less, some people need a little more, and there's other conditions that need a lot more, right?
Yeah,
so,
right.
So I'm still learning, and I appreciate you for that. But it is a great tool that has really helped. You know, I will just speak of a thyroid patient that I had that Hashimoto's, that we really couldn't get this person under control.
Oh, wow.
You know, they were just constantly up and down and up and down. It felt like every 6 weeks we were changing their dosing, and they were going through a hyperthyroid state, and that's uncomfortable. And then we'd lower their dose, and then they were constipated and depressed. And putting them on the LDN really normalized things, and they didn't have that fluctuation. So that person's been on the LDN now, I think, for 2 years, same dose, 4.5. And their thyroid has stayed consistent the entire time. We haven't had that flux anymore. So, and that feels so much better, and it's got to be better for what's going on in their body.
Right, not having this yo-yo effect going on. And I constantly pour over literature of LDN, and you know, I'd like to stay really cutting edge with things. I think it's such a powerful tool because it's one of those drugs that isn't super expensive, and if you look at risk versus benefit, there's very little to no risk for most patients, and that if it works, it's powerful. And I say if because I think there are some patients that it doesn't really move the needle for them.
But I haven't seen it be negative. Right. So that's been the nice thing, is it's something I can add on and go, let's see if this does anything for you. And if it doesn't, it's like no harm, no foul.
Right. You tried a few months, great, didn't work out, okay, fine. You didn't have a bad problem with it too. Yeah, and there's, again, I lean on Europe a lot for studies, just like you were talking about earlier in hormones too. And there's some great studies out there where they took huge data banks of patients that had used naltrexone, low-dose naltrexone, and they were doing things like quality of life surveys, and then also looking at overall drug consumption or drug use. And most of them, they found a decrease in overall medication use, especially opiates and things of that nature. And the quality of life surveys, most people felt better. And I hear that too in patients. It's like, it just makes my heart so happy to have that impact with them. Yeah, definitely. So, you know, what else kind of leads in when you're talking about this whole system person, of how you look at a person and what some of the tools that can be helpful?
Well, I think I said before, I really like to look at labs, right? And really like to see what is the organic or what's missing in your body, right? So using traditional labs, you know, looking at CBCs, thyroid, you know, looking at stuff like that. And then there are a lot of alternative labs that we can look at. Again, you know, when you see another doctor and they go, oh, nothing's wrong with you, you know, maybe you should talk to someone, right? There are lots of other testing that we can look at, you know, whether it's adrenal testing or I'll call it functional testing, right? Kind of what exists out in the world. So that's part of it, looking at the organic to see if something's going on. Personally, I really do love homeopathy, you know, and so homeopathy is energy medicine, and is a way that I think when people have some weird things that no one can quite explain, you know, homeopathy is something that can really work at someone's core and, you know, kind of, again, make a vibrational energetic change that maybe allows other things to work. Genetics. When we talk about alternative testing, I am nowhere near a geneticist. I'm not trying to be that. I know enough to help my patients, is what I'll say. And so I like to look at specific SNPs. I do a lot of MTHFR work. So methyl tetrahydrofolate reductase disorders. I I look at people's 23andMe's and kind of look at some of those genetics as different platforms that we as providers can put them through to make it so we can see where are your SNPs and what do they affect. So MTHFR affects your folate.
Okay.
But what I find is that because that process takes place in your liver, it actually affects the way a lot of people absorb or utilize medications and supplements.
Really?
So
Okay.
sometimes I'll find a patient, let's just use thyroid, it's really easy. You put them on thyroid medication and you expect you're giving them a hormone. You expect those numbers to get better.
Right.
And when they come back and they go, I don't feel any better, and I check their numbers and the numbers haven't moved at all on the labs, I'm like, that doesn't make any sense.
Where did it go?
Exactly.
Yeah.
So sometimes looking at these genetics, I can go, oh, well, your liver's not processing this medication potentially. So we can treat them for that. And then all of a sudden, 6 weeks later, they're like, oh, I feel so much better. And their thyroid looks better. And all I did was treat for one of the mutations that they had.
Right. And gave them the methylated form of the vitamin that they needed.
Yeah.
Okay, I have noticed you do that, and it looks like you customize the dose even on that. It seems like.
And again, that's the whole pro-person health, right? Like, what we can probably do another whole podcast on how drugs were invented and researched and what dose they chose, right?
God.
But
for real, and why is there only 2?
Exactly, right? And the thing is again, that's why you're a compounding pharmacist, because we're different sized people, right? We need different amounts of medication. And so that's why I do that, because the person that is 50-pound child might need 1 milligram, and the person that's a 250-pound adult might need 10 milligrams. Yeah. I've also seen it go the other way. I've seen the 50-pound child need the higher dose, right? So really knowing what you're testing for, why you're looking at it, and I would say that goes to things like thyroid, right?
Right.
I do functional testing. So I want to know when I test someone in their labs, how high is their lab when they take their medication?
Okay.
Right?
Okay.
So on 2 hours after you take it, what is the peak? Are you going above what the reference range is?
Okay.
Conventional medicine has you test thyroid usually before you take it. Right?
Yeah.
Fasted. Because they don't really look at free T3 that often,
Right.
which is definitely very acutely affected.
Right.
And so I would say that with anything, with thyroid, selenium, iron. Iron is diurnal. You're supposed to check it in the morning to see where the peak level is.
Yes.
So if you're, as a physician, not knowing what you're checking and you're just come in the morning and do a fasting.
Grab a lab any time of the day, after work's great, whatever.
Yeah, it really changes what you're looking at. So that's where the pathobiography comes in. I'm tired. When are you tired? Right? Is it morning? Is it 2 o'clock in the afternoon? Do you get a second wind at night?
Right.
Where is it in your menstrual cycle?
Oh
right?
my gosh.
For women who aren't menstruating, you might not be bleeding, but your body still cycles underneath. And so I have 80-year-old women who can tell you when they'd be ovulating or when they'd have their period.
Really?
Absolutely.
Oh my gosh.
Right? And so I encourage my women to keep a period tracker.
Yeah.
Start it when you're 25, get your numbers checked.
Or 18, or as early as you can.
And then keeping those trackers. My women that come in with a tracker that has 20 years on it is amazing. Because I can see what happened before they got pregnant. I can see how their period changed. I can see, it used to be 28 days, now it's 27. And, and you can really see that change. And all that makes such a difference and can really help me determine, this is only happening in one part of your period cycle. So it can't really be thyroid because it would be all the time, right? So, does it only happen Monday through Friday?
Right.
And Saturday and Sunday, do you feel great?
Right.
We were talking about Hashimoto's.
Yes.
I've seen patients that do great in the summer and need no thyroid and then need medication in the winter when the weather gets colder.
By weather pattern.
By weather patterns. I do a lot of hormones.
Yes.
My hormones were based, the women who invented some of the hormones that I do are based in Arizona and California. I've had to use a different base cream up here than my women in California. Is it vitamin D? Is it sun exposure and heat? Is it the colder weather and the fact that we're all wearing long sleeves versus it's still 80 degrees in Arizona in December?
Oh my gosh.
Right? So I think all of that plays into what I think that myself, our clinic, and naturopaths are good at, which is that whole person finding out where are the things happening and why and when and what could potentially be contributing.
You're like the master detective. I need to get you like a detective glass and the detective hat, because this is a lot, and it's a lot to organize and to take in and to help prioritize and to look at the whole thing, but not miss something, but also not put in too much at once as somebody can't
and I
handle.
think the big thing for patients and what you can do is I say you are a puzzle.
Yes.
I love puzzles. but I need all the pieces to put the puzzle together. Because if you're missing 5 of them, then you're like, you can't quite figure out the puzzle.
There's
right?
no edge. We're missing the edge.
Right? So that's why people that bring me, that they have their labs the last 10 years in an Excel spreadsheet, right? Gosh. Some conventional doctors especially, they don't want that because it's too much data to look at.
Right.
But for me, it might not be something I can look at right there in that hour where we're there, but taking that afterwards, knowing their pathobiography, and then really thinking about, well, what was their thyroid like before they had babies? Right. What does it look like after babies?
Right.
Oh, their mom died this year. No wonder things happen, right?
Like cortisol just shifted.
Exactly. Yeah. So really trying to figure out how that all fits into the picture, and then how we can take that and extrapolate that going forward.
That's so awesome. I love all of that. So you and I work together quite a bit. And of course, I really appreciate that. And I like being a partner in the community as well.
Well, I appreciate everything that you've done for myself and our profession. You are a huge advocate to the naturopathic profession. So thank you.
Yeah. And I love that part too. And I love education and all of that part too. So it's just a good, it's just a good synergistic little thing we've got. And I appreciate that. And I was talking with actually the executive director of WAP just the other day, and I was like, I'm just so grateful as a pharmacist that I'm welcomed into the naturopathic world and allowed to be a part of that, and allowed to have friendships in there and help patients through that too. So I appreciate that so much. So if you had to say, like, what's the most rewarding part of all of this, of all of these things you do for you, what is that? What gives you that reward? You go home at the end of the day and you're like, I've had the best day ever.
Yeah, well, I mean, I love the people, right? Okay. Like, I love doing this type of thing with you for people, but I'm not the person that goes out and lectures in front of hundreds of people. I am a doctor who got into medicine to treat patients, so I like sitting across from the patient one-on-one and having that interaction. That's really what rewards me.
Yeah.
But it's those moments when someone comes in. I had one right before we met. She's going through cancer, and in the establishment, and in the kind of just everything,
in the system.
just chugging along. And I warned her when she got into it, and she comes and sees me often to navigate that system because she's comes up against roadblocks. She comes up against people that are like, oh, you don't need that. Oh, insurance won't pay for that. I'm not going to put it in, but they don't even try. Right? And they don't, because they're not there for the patient. You're just a number. You're just another cancer patient walking through the door.
Get on the train, ride it to the next door.
Yeah, I did my job. I cut it out. Go see the next person, right? Not my job anymore. And I feel like, especially here at AIM, we're here for you until the end. And I tell people I'm kind of a bulldog. Like, I want everyone to be 100% better. Yeah. If you're at 95%, you can be like, Brooke, stop. I'm good. I'm great. You don't have to go any further,
is awesome.
Right? Yeah.
I was at 70 before.
Exactly, right? And so it's like, so that to me is it. And so the people that come in are like, you listened to me and you looked at something that I have been either screaming from the mountaintops myself, and they're not a doctor, so no one listens, or they're like, you saw something in the past, or you saw something and you looked at it, and that is the thing that made the difference for me. And so thank you for that. That's made the difference. And maybe they're not totally cured yet, right? Maybe they don't even feel that much better, but they felt heard. And that is the thing that I think keeps me going all the time.
That is awesome. And I think every up and coming want to be physician needs to go back and listen to that exact statement, because I hope that is the why of every single doctor that's going to go through a medical school program of any kind, because that's the number one priority, is the patient.
Yeah.
And helping them.
Yeah. And I think, you heard I got into medicine because of sports. Yeah. I always thought I was going to do physical medicine. Gosh. I do the furthest thing from that now, right? And because this is what came to me, and it moved me, and I saw women, honestly, when I first got into hormones, probably 2 years after I graduated.
So you were the youngest thing in the whole world at that point.
They were like, I was 29, and they were like, you're going to go talk to me about perimenopause? Like, what are you talking about? You have no idea. But it was, learning a doctor friend of mine, her mom was going through cancer, and met this other woman, and she was like, this has changed my life. And when I went and I learned it, and it blew my mind, and I have now seen so many women that have been turned down for hormones for whatever reason. They had cancer, they have a family history, they went through menopause 5 years ago, right? I'm like, when I see those women and I talk to them and I'm like, I hear you.
Yeah.
I'm not afraid of estrogen.
Yeah.
Let's go through this together and do mammograms and do the things to make sure we're doing it safely.
Right.
And they come back and they're like, oh my God, I'm a totally different person. I'm not going to divorce my husband. I'm not going to run screaming into the day naked because I'm having drenching hot flashes.
Right. It is literally like the curtains that are behind us open.
Yes.
And they can see clear through into the valley now.
Yeah.
It is literally that profound.
Yeah. And when the people come into that and they're just like, thank you. I'm like, those are the moments that I realize that I'm in the right place. And though I love physical medicine,
calling.
This is what came to me, and this is the thing that's changing lives and changing women. And that's why I'm so passionate about hormones and advocating for them, because I want these things to be around for our daughters and our granddaughters, because what the studies are showing is they're trying to pull things back and not have them. And we need compounding, because most of the hormones that I use are compounded hormones.
Right.
And without them, women are going to suffer.
Yep. So women, find your voice.
Yep.
Call up your congressman.
Exactly.
Make sure
Sign
they know
those
you're
things, sign
important.
your name.
Yeah. Yeah. It is important. And I know it's one of the reasons you advocate so much as well.
Yeah.
And so if you had to give just one piece of health advice or tip to a patient to help empower them, what's that one thing that you would say, patient, you got to do this?
Drink water.
Ooh, drink water. That's a good one. I like this one.
So I actually, one day, soon to be, you'll see a book that will come out that says, and I think the name of the book that I came up with is like, what your doctor won't tell you.
Oh, cool.
Drink water, right?
Drink water.
Because it's so simple, right? And that's really, I think, what I want to tell people is that medicine doesn't have to be complicated, right? It doesn't have to be expensive. There's so many things, preventive medicine, right? Was it an ounce of prevention is worth a pound of cure,
yes.
right? So it's doing the simple things, and I can't tell you how many people come in dehydrated, and they're tired because they don't have enough water, or because then now without water your kidneys don't work, and you can't go to the bathroom, so you're constipated, and then all your toxins get recycled, right?
Yeah.
So sometimes, just drinking water. And I like to tell my patients to drink lemon water, because getting the extra vitamin C from the lemon cures so many ailments, right?
Oh my
so
gosh.
many things.
Okay, I have to ask the question, is there a certain amount of water we should be drinking?
I think the studies say you should, some people say your body weight right?
Gosh, okay.
I think in ounces, I think that's crazy. I usually shoot for 2 liters, right?
Okay.
And then for every vice you have, so half hour of exercise, a cup of coffee, a cup of alcohol, a cigarette, a vape pen, right? Those type of things, you have to replace a glass of water. Okay. So if you work out for a half hour in the morning and you drink a cup of coffee, well, you need 10 glasses of water on your day, not 8 glasses of water on your day, right?
Okay. That is awesome. I think that answer surprised me, but I love it. and I mean, it's something we can all do, right?
Yeah.
As a matter of fact, as soon as we get done, I'm definitely gonna go get my water cup and chug it down, because I'm feeling a little dehydrated today
There you go. Yeah. So drink water, and then I guess the only other thing I'm going to ask is those women out there that are in that prime age, 18 to 25. We all feel like superwomen, and we are like, nothing's wrong. Why do I need to go to the doctor? Get a baseline.
Get your labs.
It's also important to get a baseline when you're a child at 13 to get your cholesterol and all those things, and know where you were and know how things change, because everything in medicine is about that rate of change, right?
Yes.
Where you are now doesn't matter if you don't know where you came from.
That's why you've got to get your bone density scans done right when you hit about 50.
Yep. That's why you need to go and get your mammogram and your colon cancer screening when those things are determined, because science has said this is where those things start to emerge, and we need to look for them.
Yep.
So do your screening, do your basic labs, get things done ahead of time when you're feeling great, so when people feel great, I'm like, great, let's see what those labs look like, right? Right? Like, well, how good is good? What are those numbers at, right?
Yeah.
And then drink your water.
Drink water. That's a good one. Well, we're running low on time, but I want to thank you so much, Dr. Brooke, for doing this with us. I think it's super powerful for our audience to hear this, to have this information available to them. And I know that our listeners are going to really enjoy it. So what, if a new patient or somebody wants to connect with you or your office, what's the best way for them to connect with you?
Yeah, you can check us out at AIM4Health NW, like northwest.com.
Okay.
And if you look up AIM in Redmond, you will find us. We're the only clinic up here. And so I think those are really easy ways to get us. And I think, for those of you that might have a conventional doctor already, having a naturopath on the side side as adjunctive care to your conventional care. And you also might encounter what we were talking about, older doctors that are more classically trained, that aren't up to date on some of the new hormone information, that aren't going to be willing to go down that road or have that conversation. But that doesn't mean that you're not capable of taking hormones. So it doesn't mean you have to fire that doctor either. But I think ask questions, ask, honestly, pharmacists are great referral sources that you can ask, like, hey, do you know someone that maybe does it? Because you have lots of doctors that prescribe to you, and you can find someone near where they live. So it's, I'd love to see everyone, obviously, but we don't live near everyone, and they don't live near us. So I just want people to advocate for themselves and ask questions and, read books and, don't take no for an answer, right? Like, if
know your body.
Know your body. You're the one who lives in it.
Yeah, I agree. Awesome. Well, thank you so much. That's today's episode. Thank you for joining in. If you liked what you heard, be sure to please give us a like, a share, a comment, and stay tuned for more insightful discussions on health and wellness. Until next time, take care.